Well, good morning. For those of you who don't know who I am, I'm Margaret Gray, and it's my privilege to serve as the 9th Dean of the Yale University School of Nursing. And I am delighted to welcome you to what is an annual event here at the School of Nursing, the annual Bellos Lecture. But this year, we celebrate Nurses Week with a scholarly symposium that celebrates the contributions of Yale nurses to nursing science. As you know, this year marks the 90th anniversary of the School of Nursing's founding, with the opportunity to create First Dean Annie Goodrich's vision of educating nurses in both the art and science necessary to care for people. Not only did her vision revolutionize nursing practice and nursing education, but in the late 1950s and 1960s, transformed what nursing research was about. Prior to those days, what research there was in nursing focused on what nurses did. Some of you may remember studying in history of nursing courses the time and motion studies, where people followed nurses around and figured out what they were doing and how they spent their time. But in the late 1950s, early 1960s, nursing leaders like Rita Dumas, Donna Deers, and many others came together with people from Bob Leonard and others from the Department of Sociology here at Yale to create a new definition of nursing's approach to the study of patient care problems. And clinical nursing science was born. Indeed, the first ever federally funded nursing clinical trial happened here at Yale, with Rita Dumas as the principal investigator before she finished her master's degree. Today, we celebrate the legacy we inherited and look toward the future of nursing science. Now, I could go on and on about this because I think it's a fascinating history, and I invoke the spirit of Donna Deers, wishing she was here to wax eloquently about her experiences during those times, but sadly, she's with us only in spirit. But I thought a letter that I recently received from Sally Thorne, professor and former director of the University of British Columbia School of Nursing, would state it best. She wrote, "Dear Dean Gray and Yale School of Nursing colleagues, I was very appreciative of receiving the invitation to your 90th anniversary celebrations and regret that I cannot be there in person. Perhaps if there is a collection of tributes, you would be so kind as to add my note to it. The Yale School of Nursing has been a beacon of excellence in nursing education and scholarship for 9 decades, and this is indeed an occasion to celebrate. I was thrilled to see that Ada Sue Hinshaw, I'm sorry, I do know your name, would be your featured speaker for the event, an icon in American nursing and international nursing thought. Someone who has led the path through so many of the strategic and political trials of our profession in an era of constant change and challenge. And so many other marvelous practitioners and scholars have come from the ranks of your graduates, a tradition to be proud of. I have so much enjoyed my visits to your school and my interactions with many of you over the years. I have greatly appreciated the colleagueship and enthusiasm for ideas that have consistently come from your faculty. So on this happy occasion, I salute you all and wish you a delightful event. Now I have a few housekeeping items. Should you need a restroom, and given that we're going to be here all day, I will expect that most of you will need a restroom. So you go out of this, make a right past the stairwell, and just follow it down past the reception desk, the next hallway, the women's room. They're both to the right, but the women's room is to the right, and the men's room is to the left in that hallway. And if you want CEUs, you need to sign in and sign out at the registration table, complete the evaluation form that is in your packet, and then they will hand you your certificate when you leave today. So on to the Bellos Lecture. Many of you are already familiar with the background of this lecture, but it is a tradition for us to tell it every year. The lecture was established in 1964 in honor of Sybil Palmer Bellos, I don't know what is with names today, so prepare yourself. A 1927 graduate of YSN, on the occasion of her retirement as the director of the Northern Westchester District Nursing Association, Mrs. Bellos was known for qualities apparent from the beginning of her nursing career: dedication, vision, and a sense of adventure. A woman of great personal charm, modest and gentle, Mrs. Bellos was able to reach and touch others, and her influence has been felt far beyond her expectation. Each year, the Executive Committee of the school nominates a candidate to deliver the Bellos Lecture, a candidate whose work and reputation reflect qualities attributed to Mrs. Bellos. I think you will agree that today's lecturer embodies those qualities. In June 2008, Dr. Ada Sue Hinshaw was appointed as Dean of the Daniel K. Inouye Graduate School of Nursing at the University of the Uniformed Health Sciences. In this role, she is responsible for overseeing all of the Graduate School of Nursing's master's and doctoral programs, as well as developing future leaders of military and public health. Before joining the Uniformed Services University, she served as dean and professor at the University of Michigan School of Nursing from 1994 to 2006. She was elected to serve as Distinguished Nurse Scholar in Residence at the Institute in Medicine in Washington from 2006 to 2007. Dr. Hinshaw was the first permanent director of the National Center for Nursing Research the director of the National Center for Nursing Research and the first director of the National Institute of Nursing Research at the National Institutes of Health. She led the Institute in its support of valuable research and training, many of whom have benefited from that work, are in this room, and focused on many areas of nursing science, such as disease prevention, health promotion, acute and chronic illness, and the environments that enhance nursing care and patient outcomes. Prior to this, she was director of research and a professor at the University of Arizona College of Nursing, director of nursing research at the University Medical Center's Department of Nursing, and she held leadership positions at the University of California, San Francisco, and Kansas University. Throughout her career, Dr. Hinshaw has conducted nursing research focused on quality of care, patient outcomes, and measurement of such outcomes, as well as building positive work environments for nurses while ensuring patient safety. She has given hundreds of presentations, and her findings have been widely published in numerous articles and books. In addition, she has served on numerous scientific advisory committees and task forces and has been a visiting professor at various schools of nursing. Dr. Hinshaw has received many awards and honorary doctorates, including the Midwest Nursing Research Society Lifetime Achievement Award, the Health Leader of the Year Award from the United States Public Health Service, the Elizabeth McWilliams Miller Award for Excellence in Nursing Research from Sigma Theta Tau, the Distinguished Leader Award from the National Institute of Nursing Research, Nurse Scientist of the Year Award from the American Nurses Association Council of Nurse Researchers, and the IOM's Walsh McDermott Excellence in Service Award. I could go on, but you'd rather hear her, not this list. And most recently, she received the 2012 Policy Luminary Award from the American Association of Colleges of Nursing. She's been involved in many professional organizations. She was the past president of the American Academy of Nursing, a member of the Institute of Medicine and its governing council, and vice chair of the IOM's report on keeping patients safe, transforming the work environment for nurses. She received a bachelor's degree from the University of Kansas, a master's degree in midwifery, of all things, from Yale, and a PhD and MA in sociology from the University of Arizona. Since Mrs. Bellos was concerned with the health of the public, and YSN's mission is better health for all people, I think you will agree that Dr. Hinshaw is a great choice to be our Bellos Lecturer. Ada Sue, with sincere gratitude for your work on behalf of nursing and our science, I welcome you back to Yale as a 2014 Bellos Lecturer. Do we have to do anything here? Okay. All yours.
Thank you for that gracious introduction. It's just always fun to be home, right? All of us feel that way when you've had the opportunity to be one of the alumni from Yale University School of Nursing, to say the least. Today I selected, obviously, the fireworks design for PowerPoint, made it blue for Yale, of course, but read this as fireworks and as celebrating, okay, which is what we are doing with this particular piece. Wanted an opportunity to tell you some of the story about the history of nursing research and our celebration for science, and also to give you some of the background for where Yaleys have come into that. Now, Margaret stole some of my thunder, but that's okay, I'll forgive her. I didn't know that Rita Dumas was the first funded researcher. I knew she was our first researcher doing practice research and experimental designs. So that's really fun to find out and to learn, to say the least. But today, really, what we're doing is to look at all of the different ways in which nursing science has now been developed and is now really impacting both nursing practice and nursing policy. It's been long our dream, I believe, that we've known that the purpose of research for us is to, in fact, improve professional practice. And then as we grew and matured, we understood that impacting health policy at all levels, from organizational patient care policies to national legislation, makes a big difference for us. And it impacts hundreds and thousands of people when we are able to do that. So clearly, the 90-year document that we saw in the fall shows many people who have had an impact on this scholarship. And today I'd just like to take us through experiencing that journey and looking at both our history and our way forward and some of the fun opportunities we still have as we face our future challenges as well. So scholarship is a broad term. It goes all the way from clinical scholarship and translation of research into practice, evaluation studies, to the actual scientific inquiry and the scholarly and to research. And today I'm really going to focus on the evolution of the science itself and on research, not as much on the translation piece, although that is extremely important, and now we're really building a science in that area as well with implementation science and with the translations we're doing. Okay? So we're going to examine several things. One is the history itself, Yale's different influences at different points in time, the established structures along the way that have allowed us then to really build our research programs. So we'll talk about NINR a little. There's some fun stories around that. And then looking at the multiple areas of emphasis that nursing as a discipline, you can now tell, are really bringing to health and healthcare science in general. So when we produce science, we produce it for all people and all professionals. But we particularly know that it fits our practice and our perspective on what's important in professional practice. And we are beginning now to have a real impact on health and healthcare science in general. And that's fun to look at now that we see the effect of our people's work. Now, you always have to start with Florence, okay? There's no way around that. She was, for many people, the first statistician. For public health people, she was the first epidemiologist. For me, she was the first evidence-based nurse administrator. You know, we have only used those terms recently in relationship to nurse administrators, but that is now how we talk about nurse administration and the decisions they have to make, evidence-based. Our discipline also claims her as the very first nurse researcher. And this is very real, very logical, because she changed practice and she changed policy based on data she generated. And just to give you one example from her notes, this is always just a little foggy because those notes are very old, as you all know. But if you look at the center area around the salmon color, she looked at all the deaths of the soldiers that she cared for. And those that are in the salmon color are those that were deaths from the wounds that they actually experienced. Now, I'm in the military right now with the Department of Defense. And so this means a lot to me in the sense of what they were dealing with. There were a few other complications around the edges, and that's the brown area. The entire gray area are those deaths that occurred because of diseases in the hospital, things that came from the environment. poor environment, poor sanitation, poor nutrition, etc. Things that were preventable. That's horrendous when you look at that graph and understand that that is what she changed. She walked into that and she said, let's get some data on what's happening here. Let's look at that data and let's change how we provide care. And she did so. Now, we've also got some very early foundations for our disciplinary research. And one of those is very much a Yale piece. And that contribution is when Dr. Annie Goodrich Dean Goodrich took Yale University, or the School of Nursing, into Yale University as one of the first 2 schools in the country. Helen Burst says this very generously in her history. You can tell I used that for this particular talk. And talked about the fact that she generously shared credit with one other university, School of Nursing. I think that was Columbia. I'm not quite sure. And frankly, I think I'm not supposed to say it aloud, according to Helen. Okay. But in fact, this was the very first step. That was a turning point for us in our discipline. Once we were into universities and then began to meet and set all the standards for nursing that were in universities. Universities are the place in our country in which research is acknowledged as a prime responsibility. And because of that, we then became credible to be able to move forward with research programs as well. We could never have done that without this placement in universities. So it was really a turning point for us when Yale and the other nameless school moved forward to move into their university settings. Now, from the 1900s to the 1950s, as you were indicating earlier, we really studied educational curriculums. We were new in the universities in 1932. We didn't know a lot about university education or what that would look like for nursing. We had a lot of work to do, and so there was a lot of evaluation and a lot of development of curricular work during that time. We also, during that time, began to study ourselves. Now, why we have felt the need to examine our belly buttons, I've never quite understood, but we do, okay? And we went through an entire area in which we looked at who are we, what do we do, etc. I suspect part of that, and I can't get in the heads of those people, of course, but I suspect part of that was the whole question of, okay, now we're in universities and we're nurses. What does that mean? How do we go together? How do we understand ourselves in the context of a university and being a scholar and being a researcher as well, and an educator, as well as being a professional nurse? So my hunch is that a lot of that was our trying to understand who are we, now that we're in a very different set of situations. We also, during the 1950s and 60s, moved forward with nursing research. Now, establishing a journal, 1952, first one, and the others didn't follow till late in the 70s, it's very important to think about what this brought to us. This brought to us the ability to put our ideas on paper, to have them critiqued by each other and by other disciplines. No science can move forward without critique, reevaluation, and reformation. So the Nursing Research Journal was extremely important because it brought us that ability to critique our work, ourselves, to have our colleagues critique our work, and then to have times in which we talk to each other about that work. And we generated new ideas, and we thought about new ways to handle problems we had had in that research. But that was our first journal and our first opportunity to really get into what is a very basic premise and practice for any science, okay? So it was interesting to see that happen. We also had several centers that were established during that time to begin to facilitate nursing research. Now, one of the things that was also very important were that our schools of nursing, like Yale, were at that time producing people who could do nursing research, and mostly with master's degrees. That's where we began. Now, I don't know how many of you remember this, but some of us do, when most of us did have master's degrees, and we were struggling to find out how to go back to school and how to get through the doctoral programs that we needed. But Our very early research came from master's prepared individuals. Then, under Dean Arnstein, in about 1958, according to Helen, you notice I'm quoting her again, okay? Yale really took on the mission of figuring out how to facilitate and build faculty research. It was one of the first schools of nursing to do that formally and very clearly. People like Bob Leonard, Philpott Wooldridge, James, Dickoff and James were very important to our work at that time. Now, Margaret often tells the story about how she came to Yale and got turned on to research. I studied with these people, 61 through 63, and they were so exciting. And the whole premise of building research for nursing practice and nursing science was just a fire here at that point in time. And I looked at poor Miss Ernestine Wienbach and said, I'm not going to be a nurse midwife. I'll be a maternal child health CNS, but I'm in love with research. I'm going with research. I don't think she ever quite forgave me. She was a marvelous individual, and she believed in really facilitating people at what they were good at and loved. And so she did that and did it well. And I will be forever grateful. But that is literally where I started, with that excitement, that early beginning with what nursing research could be, but what we had to build it in order for it to be. And that started here at Yale. It's one of the major places in the country. Now, in about the 1970s and 80s, we had a turning point. We moved from studying our educational curriculums and ourselves to really beginning to study our professional practice and asking the questions around our professional practice. And that was a very key moment in time for us, because it then started us down the kind and number of research programs that you see today in terms of our research. Now, here is just exactly what Margaret was referring to earlier. Yale faculty and alumni were very much a part of this. Rita Dumas, in 1972, published one of the first studies around perioperative emotional preparation for surgery and the effect on perioperative outcomes or post-operative outcomes. You remember some of those studies. We're still doing some of those today, greatly refined, of course, but some of those studies. That she was reporting on a series of 5 clinical studies that had been done. And it was not only some of the first early examples of professional practice research, it was also some of the early professional experimental designs used by nursing in their research. Okay? So it was fun to see the impact that Yale had at that point in time. Jean Johnson, who was one of our alumni, she was here in the fall, one of our 90 people as leaders. Jean Johnson has studied for years sensory information and distress response. She's done this with all kinds of situations, and the latter part of her career went into oncology with this area. But Jean is one of the few people in the country that, besides Rita, that you could talk about had a program of research. Most of us were still doing our doctoral degrees, doing a study, and going into something else, and never pursuing our research. So it's a really fun history to think about in terms of Jean's background and capability as well. Okay? It was about this same time that we had the standard set that nursing research would be theory-driven. People would worry about the theoretical frameworks. We would worry about not just hypothesis testing in the sense of a couple of variables, but how that all linked to a greater sense of a theoretical sense of why those relationships worked. And that was some of the very beginning times when we set the standard then for the nursing theory. Ida Jean Orlando, we're all familiar with her work on her process theory. And Jean Johnson had put forth a very simple theory at that point in time. Don't know how much of this you can see, but it's really very exciting to think about the work that she did, because she clearly was studying experimentally, if you took casts off of children, what kind of information helped those children to deal with the pain better and the distress better, okay? But what she did was link that all the way back up to, if you provide sensory information for people in distress situations, they will have more positive outcomes. That was a refinement on the Dumas work on perioperative and postoperative outcomes. She was now saying it's not just patient education, but it's sensory information that makes a big difference, okay? Very simple, very elegant, early theoretical study, or theoretical system that she tested at least 12 to 15 times. Numerous studies that were done in this area. So a well-substantiated relationship in that sense. Now, our theories have gotten much more complicated because we now attack many more complicated problems than we did. But it's fun to see how one of these very early, simple theories have really held over a long period of time. We also then began to put in place the infrastructures that we need. You can't do research without a strong infrastructure around you to help facilitate it. And that goes all the way from deans and directors of nursing services to structures that provide funding, to your professional associations who provide conferences. It's a whole series of ideas that are needed to make these really be available in that sense. Now, to begin with, what we had done was we had the Division of Nursing. And we were doing research and research training or education out of the Division of Nursing at that point. And I don't know whether any of you remember Dr. Doris Block, but Doris was a Yale. And she was very, very instrumental in the early pre- and postdoctoral scholarships, fellowships. And she was very instrumental. She was the author, with her colleague Susan Gortner, of the program of funding that funded all of our doctoral programs as we built strong nursing science doctoral programs and brought in other disciplines and really helped ourselves to begin to build our doctoral programs in these universities. Doris was key to that, and she was a Yale. Now, many other things also occurred. Most of our universities have offices or centers of research. We've also got regional and national nursing societies. All of that provides structure in which, again, people can get together. They share their research. They share their ideas. They generate more ideas, and they critique. And we've always in nursing prided ourselves on being ones who could critique constructively and help each other build. We've never tolerated in these conferences some of the kind of destructive critiques that you can see. Those people got isolated very quickly. I can remember one person once having given a critique, very scholarly done, but more negative. And later she said to me, I really worked hard on that. I don't know why anybody didn't want to come to lunch with me. Okay, no, nursing never tolerated that. We always said, not going to happen that way. So I said to her, well, the issue is how you tell people what they need to hear. And you tell them in a way that they can hear it. Not in a way that makes them angry or makes their audience angry, and then they don't hear it and neither does anyone else. So it did help, I think. But you could see that nursing has always taken that particular orientation. So here's just some running examples of the kinds of conferences and councils that we've had over the years, from the national ones to our regional ones, which are all very important. And then the ones that are done in our schools of nursing, like today when we listen to scholarship and celebrate what's happening, okay? Now, one of the biggest turning points in our nursing research process has been that of the establishment of the National Center for Nursing Research, and later that being redesignated to an institute. That brought us resources and stable growth and funding that we had never been able to have before. The Division of Nursing was a fine place, but it was for education, it was not for research. So anytime Congress allocated money to research, we didn't get any. We had to rely on our few champions in the Congress to always remember they needed to put a couple million in for nursing, but that's all they put in. So I can remember the years when we had $3 million for the entire country to fund research. And that was a time in which, talk about funding problems, they were big time. And nurses didn't get serious about research because they couldn't get it funded. You're not going to spend a lot of time and effort trying to do something that, in fact, you can't get funded. You can't get rewarded for, you can't see come to fruition, you can't share with your friends, okay? So that was very critical that the National Institute for Nursing Research finally came about in that time. And it gave us all of these different parts that were important. The one I haven't spoken to is that it took us into the mainstream of science, health science. And because of that, it brought a richness to our research that I think we had never seen before. Nurses are great as collaborators. We know how to collaborate. We know how to negotiate. We do it all of our lives in our own professional positions. And as researchers, those skills translated greatly. And that meant that we had people from all the institutes who were interested, willing, part of our research studies. In our universities, we had people from all the other disciplines as well, from medicine to public health to pharmacy to dentistry. We have pulled in sociology, everybody that we needed when we needed them. At Michigan, we had a person who worked primarily with bioengineering because that was what she needed for her research. But we had never had that opportunity before. We didn't have the funding to be able to do that before. And to help our colleagues to understand that this was serious research. This was credible, legitimate, serious research. All of that is what the NINR has brought us in the sense of the reputation and the background. Now, I'm not going to go through each one of these separately. Let me just say to you that in the fall of 1983, the legislative process was started, and a Yale, Dr. Jan Heinrich, who is a doctoral graduate of the School of Public Health at Yale, was the individual who was the major lobbyist for the American Nurses Association as we moved the Congress to pass this legislation. That's not as well known in the country because, and particularly to Yale's is not as well known because she wasn't with the School of Nursing, she was with the School of Public Health, but a very strong individual. Now, through the fall of 1985, they worked on that piece of legislation for the first time, and it went down to a veto. And there was no legislation that came back into session again. So it could not be passed. The entire thing started again in 1985. And by the October of 1985, we had a negotiation to establish a national center for nursing research. Now, that's always a fun story, and many of you may have heard me tell it. I'm sure Margaret has. But I was working with the Cabinet on Nursing Research at the time, and we were doing the policy direction for the ANA, who was the lobbying group, chairing that cabinet. So I can remember we set up a call, which I missed the timing off because I was in the West, in Arizona. So I'm in this, and I'm up to my elbows in cookie dough. October, we're going into Halloween. My son and my daughter were making cookies, okay? So I'm standing on the phone with my phone like this, trying not to get it too dirty with cookie dough, talking about what are we going to compromise if we're willing to compromise for the NCNR, the NINR. I've always laughed about that, so for me, this is cookies and compromise, okay? It's always had that label in that sense. And what we compromised was we said, okay, the legislation has always from the beginning talked about a National Institute for Nursing. We didn't end up with that one at all, anyplace. We're willing to compromise the label. We'll be called a national center, if that will make NIH more comfortable with us coming in as a national center with, I think at that point, something like $11 million. The next closest institute was $120 million. And NIH was really concerned that they have an institute that small with that little money. So we said, okay, we'll compromise the label. We will not compromise the language. So when we passed that legislation had all the authority to build an institute. It just had the label of a national center. And that was key because we never had to fight again about can we or can we not be an institute. We had to simply build the monies, build all the programs, and then say, see, we've got all this in place. Why can we not be an institute? And it worked, okay? And that's literally what the profession and we did to be able to get that through. And it was a key turning point for this legislation in that sense. The president did still veto it. And it made the Congress furious. We had a couple of champions in the House. We had a couple of champions in the Senate. They thought they had negotiated this whole thing out with President Reagan. He went ahead and vetoed it anyway, and they were mad. And that got passed, both the House and the Senate, without a qualm, without a drop of problem. They simply brought it up, voted on it, passed it on. And that had huge majorities because everybody was mad. Okay? So the politics sometimes have a very interesting way of making this spin for you. And that is what happened here to get that. And it was established then, as you indicated, in April of 1986. In that sense. Yeah. Now, there are many things that got us there. And probably the biggest lesson for us to learn from it is the unification and the political will of nursing. Because if we want to move this again, and we should, we need more money under this. You heard me say that as Ada Sue Hinshaw, citizen. I can't lobby as a federal employee, okay? Right now I'm in the Department of Defense, so I said that as me. But we need to be lobbying for more money. And that would take a strong political will and unified position again. We also had phenomenal champions in this. The unification pieces, ANA and the Tri-Council had gotten all 75 specialty organizations on board with them. Everybody signed this thing as it went to every member of Congress. Everybody who went to the Hill to talk to the congressional people talked about this. One voice, one message. It was very, very powerful. See Judy looking at me. For those of us who teach health policy, we really you have a sense of what this means in that sense to get that done. We have marvelous champions. That's always necessary. We've just recently lost one of our favorite champions. That's Daniel K. Inouye from Hawaii. So we have some rebuilding to do. We will do it, but we do have some rebuilding to do, to say the least. There was a lot more visibility of nursing research around that time because we were really working hard to be able to talk with all the Congress people. And the Council and the Cabinet on Nursing Research were in all the time to talk with the legislators. Some of us were even at NIH talking with people who didn't exactly want us, but needed to know who we were because we were coming. And so we went to talk to them and had some very interesting conversations. And I must tell you that having said that, once we were a national center and a national institute, NIH was phenomenal. We were then part of them. We were their family. We would be good. And they were fantastic. So early years where we had very little money, like $11 million for funding, we doubled that to 30 and 40 million every year by virtue of other institutes being willing to take applications that we received and fund them. And that was not just because they were trying to help nursing. That's because they were so surprised nursing had really good applications, and they were good topics. So there was a lot of education to do, a lot of teaching to do, but we got great support for that as it went on in that sense. So the redesignation then occurred, and that happened because, in fact, our professional associations again went forward to redesignate this as an institute. Dr. Bernadine Healy was the NIH director then. She had been president of the American Heart Association. Any of you in cardiovascular and knew Dr. Healy? She was a phenomenal lady. And as she went to be president of the American Heart Association, it was the Council on Nurses in the association that lobbied so heavily for her. So she always loved nurses. We couldn't have been in better hands. So it was very easy to get her to support the legislation and not to have NIH counter it. Now, that silenced medicine and it silenced the NIH, so that the institute legislation went through without any trouble. We were no longer battling with some of our colleagues who just didn't understand what it was all about in that sense. Okay. So today you can see the change in what we have for resourcing nursing research. from 11.2 million to 144.2 million. We've done great in being able to really have that available. I also have to say that, thank goodness, the Division of Nursing had educated people so well for their PhD roles and had a large cadre of them ready to go. So that center, later institute, was successful because we had people out here in the field who were ready to apply. We had the people who could do the research and were ready to apply. And that was very critical. And that was all due to the Division of Nursing. Now, 3 Yale alumni were central to establishing the NINR and the NCNR. Myself, who quite frankly, I didn't know I was going to be the first director. That happened kind of by default, simply because they said, we want you to put your name in with some other people putting your name in. I said, okay, fine. I had my own research. I was busy. I wasn't watching what I was doing. And went to interview, had great interviews, good discussions. Went home again. I thought, well, that's the end of that, but at least they've seen we have a cadre of people who come in and interview for this position. And Weingarten, the NIH director, called me and said, Ada Sue, we'd like to offer you the position. And I said, I don't know whether I want it. I don't think he ever quite forgave me for that. I told him the story, and he said, well, make up your mind and call me back. So all of this was kind of a fun exercise in some ways. Dr. Doris Bloch was, quite frankly, the extramural director when we moved from the division over to the National Center for Nursing Research. She was exquisite. She was another Yale. She was very active in the doctoral program development for nursing. And so she was a very special person always. And then Dr. Jan Heinrich then came in to be the deputy director and the extramural director. And she has her public health doctorate from here. Another turning point that Dr. Bloch was very involved in was the nursing research agenda and the setting of priorities. Remember I said that we were kind of doing our dissertation work, then a study, and then we would move on to something else. And those A studies tend to be in all the fields of nursing research that you can think of that you could do research in. So we quickly were going to have to get a focal group of substantiated research that we could testify in front of Congress and the NIH, made for a strong body of science that was built in science, not scattergun. Couldn't have a shotgun effect. And literally, the National Nursing Research Agenda, with its priorities, was set up to give us that opportunity to do that for us. Now, many of the things you see here are still things that we're very committed to. We've grown, we've refined them, we've now taken them in directions that we know are most critical in the discipline, but they very much are things that you can tell are nursing issues, nursing concerns, and we're still pursuing many of them today. So it was fun to see that happen. It did, in fact, focus the research. When you put money into something and throw money at it, believe me, people decide they can study that. And all at once, we had people who were applying in these first 7, and the first 6, and then in the second 5 and 6 that we had. But that was important because then we could say to the Congress, here's a series of studies that are being built in this area. We didn't have results. We can only talk about here are the studies that are being built. This is what it'll tell us. This is what it ought to do for us, but. And now, of course, they have beautiful bodies of research that they can testify with without any trouble. Very different now than it was, but that's the way that we got people to pull together, stop the shotgunning effect, and really get serious about substantiated areas of science. Very, very critical for the nursing science development in that sense. We knew we were coming when finally we got a Wall Street Journal article. Beyond tender, loving care, nurses are a force in research. Okay. Took us a while to get there, to get it, in 1991, but that was a very important turning point as well. It began to say to the American public, as well to the Congress, and to our own people, that we're being seen differently. We now are seen as scientists as well as professionals. It's important to put those two together. A lot of things happened with the scientific work, with the establishment of the cadres of researchers working with the NINR. Before when the CNR just went into place, we were arguing among ourselves, both in the literature and in our conferences, about was it better to do qualitative research or quantitative research. And quite frankly, at the center, we said, stop this. This is not a necessary argument. Use mixed methods. We're putting both of them together. Use the one that's right for the question, but don't talk to us about one or the other as a bias, okay? And quite frankly, the discipline turned very quickly off of that. We moved from descriptive to experimental to model testing, many systems. Now we're into biobehavioral, as you all know much better than I do, and that's very exciting to see. You were talking last night, Marie, about some biomarkers you're using now. But we've moved a long way with the science to really begin to put the biological and behavioral together and understand how it works. And we've turned, almost everyone has now developed long-term programs of research. We teach that's what you do in our doctoral programs. We facilitate people doing that with the funding. That's exactly what needs to be done. So we have substantiated bodies of knowledge that we can talk about and we can use. We can actually put in practice and into policy. It seems to me as I look back, our disciplinary perspective brought several things to health and health care. Clearly, the whole concept of patient-centered care. We may have to have some discussion about that. I think Shirley was talking about it earlier at breakfast. Where's Shirley? Okay, there you are. So we may have to have some discussion about that. But there's much more attention to that than it was. Thank you. The emphasis on health promotion is clear. We were funding at one time close to 60% of the portfolio on that because nurses are big on promoting it, preventing it, and not curing it. Very much our orientation. The whole concept of symptom management and now self-management has really grown into a major field now in which other disciplines talk about it or using it, but we're really the ones who emphasized it heavily, brought it in, etc. And it's fun to see that as to what we've done. Preserving dignity, working with end-of-life care, which is a very big one for nursing, as you know, we're in the National Institute. And then defining clients broadly in broad contexts. And quite frankly, dealing with the complexity of what that means. Not worrying about dealing with simple questions or more reduced questions in that sense. Now, this is just an example of Norma Matheny's work in which we now know that that research is well into professional practice. She looked at the placement of nasogastric tubes and how you tell if it's in the right place, i.e. the stomach and not the lung. Her work is very clear about what she was able to show with the pH. She then put together a very simple pH test, and that entire test now has been written into our textbooks, medicine, nutrition, nursing, as well into many of the practice policies and national guidelines. So it's exciting to see an example of that. An example in the more health services area, Mary Naylor's work, we're all familiar with her work, with using advanced practice nurses in the field after people are discharged. That work, of course, was written into the 2010, excuse me, that work was written into the 2010 presidential budget. Her work shows the readmissions issue and the cost issue big time, and what could prevent readmissions, i.e. advanced practice or practicing nurses in the field with these patients after they've gone home. AARP started legislation to get that into place for reimbursement. They did not need to continue. It is written into the Affordable Care Act, 2010. So all of that, she had a huge impact on national kind of initiatives with this. So just to mark the incredible progress that we've made and to be excited about that, I think is the important thing for us, to know how far we have come and to also think about many of the challenges and opportunities that we are still looking at. That's going to be very important for that. It's important to know also that if you look at some of the many future reports that are coming out now, that have been out for just the last few years, in 2012, the new NIH strategic plan was out. It was on the web, I think, in 2011, so we've all been using it and looking at it. Also, the Future of Nursing report and the 2013, the most recent Institute of Medicine report on informing the future. We fit with our kinds of research very clearly for the opportunities for the future. So I would simply ask you to take a look at this. Clearly, they resonate well with the kind of issues that are important to us: wellness, promotion, symptoms, self-management, and end-of-life care. We've talked about all the way through. It's been part of our history. It's now part of our future, to say the least. The Future of Nursing report really wants to get full scope of practice for our professional practitioners, our advanced practice professional practitioners. That's important because that offers us a lot more areas for research and understanding how our practice can really improve patients and families and clients' care. And then, of course, needing the higher levels of education for people, both PhD and DNP. I think it's so exciting now because we're just at the beginning of the new DNP degree, as it will be able to translate the research off our PhD cadre and PhD research any place, but particularly off of our cadre of nurses. But the exciting part is now we have an infrastructure that literally makes that translation a very deliberative process. That's not true for all the other professions. So being true to our feeling that research is for a purpose and research goes into practice and policy, it's very important to understand that we now have another very important infrastructure to support that. It's going to be fun to see in the next 10, 20 years just how we make that happen, how we operationalize that. But it's one of the really fun challenges. There are 7 new areas that the IOM report brings out for this next year that is so critical. Their reports now are being written heavily in the area of health and with an emphasis on health, which is very much to our advantage in terms of our interests and our way of approaching healthcare and research in that sense. So you could see a number of things that they are suggesting are going to be very important in this next year of the research world. Okay. So we have many opportunities. That also means many challenges in that sense. And I'd be glad to take questions or comments. Questions or comments? Oh, go ahead. Yes, Marie.
So you're probably familiar with just in the past month the development of an office for palliative and end-of-life care in NINR.
Mm-hmm.
So can you speak to what the implications of that would be in terms of the structure and sort of how that will help move the agenda forward in that area?
Well, as you know, NINR is the lead institute for palliative care and end-of-life care, which we have been thrilled about being able to be that particularly in that lead. But providing an office means that you're going to funnel monies. You're going to be sure there are always program announcements coming out. You're going to be doing conferences with the scientific community's thoughts on what needs to be funded and needs to be really supported and where the new areas are that are evolving for that. It gives the infrastructure again that really focuses on a particular area. We've never done that before. It's really a step forward, to be quite frank. Always before we've talked about nursing research in general, and we have branches, but we've never had offices for particular areas of science. And so it's again kind of a refinement of the structure, a refinement of the sense that we're taking responsibility for this and evolving science in this area. I think it's going to be really critical. I think we'll see a lot of work in this area because of that office's structure. We'll see. It's always fun to get to be a guru and not have to be responsible for it, right? Yes, Margaret.
Thank you so much. This was great and exactly what I was hoping. So my question is, you talked about how the funding at NINR has grown. $144 million seems like a lot of money to a lot of people, but it isn't a lot of money. And I know you work for the government, so do this as a private citizen.
Thank you.
Talk about the role that we should be playing in assuring that We're still the smallest institute. I mean, even complementary and alternative medicine has way more money than nursing. So what should we be doing to ensure not only the future of the institute, but in an era of decreased funds overall for research, how can we continue to grow this so our science continues to grow the way it needs to?
That's a great question. We goofed when we went through the earlier processes. We gained $5 million when we moved from the Division of Nursing into NIH, not nearly enough. But at that time, everyone was worried about whether we really had enough researchers who could use the money. That's clearly not a question anymore. That's clearly a dead issue. And when we went from a center to an institute, we did not ask for money. That was the big critical issue. We should have asked for $50 million at that point in time, speaking as Ada Sue, okay? Now, one of the reasons I shared with you the very successful strategies for getting the NCNR in place is that those exact strategies are what we need to reinstitute. We've got to rebuild a couple of champions because both Kennedy and Inouye are gone, and they were biggies in the center. So it's important now that we begin to look at where we can build major champions who would take on nursing as a cause, okay? At the same time, it's going to be important to get our professional associations all unified again. And frankly, that first year that we had the legislative bill go down to defeat was the best thing that ever happened to us because we weren't even together internally. We had people who were saying, we shouldn't really try this because it was going to hurt the Division of Nursing. And there was a lot of concern about that. And we took a risk on that. We honestly did take a risk on that. They're now, what, 250-some million? So I don't think we hurt them. We certainly didn't hurt ourselves, now being at 144 million. But we need a lot more money. We are still less than 1/10 of 1% of the NIH budget. That's appalling for the kind of research that we do and the impact we're now having on practice and policy to not have any more funding coming into that. But it's going to take that unification and that those champions. Nursing research we're still not always seen as scientists. And as much as we're building that reputation very hard, we've got a lot of work to do. Shirley?
I was just going to add to that and build on your last comment from a policy perspective. The other thing, a political lesson, is we need to build from the grassroots, not only within the profession but outside, and demonstrating what nursing research does for the bottom line, what nursing research does for quality of care. And so somehow we need the masses of nurses and others to begin to recognize, appreciate, utilize, and get engaged in that process. And I think there's some real opportunities. Because even though we prepare all of our students at the baccalaureate level about research, you can ask them when they become graduate students and in other settings, they don't really understand what it does for practice and for outcomes. So I think that that's another strategy that we can utilize to really build capacity in the system, and that influences public policy.
And I think we could do that from the basis of the evidence needed for their evidence-based practice. I mean, that's become a big thing for our professional practitioners. And nursing is really doing well at picking up that concept and moving it. Now, not everybody, but we're doing better percentage-wise than some of the other disciplines. Well, if we built on the idea of the additional evidence, where we need more evidence, what we're minus, what those gaps mean for our care and for our professional practice, and what we can't do, that will make a big difference. And I think we could come at it from that to build a grassroots, because we need those 75 organizations, all speaking with one voice once again. It will not matter if the Congress understands nursing research or not, if 75 organizations and all our general organizations are saying, we want, and this is why. Give them a good reason why, because then they've got all the reason to say yes to supporting you. But you don't say no to 3 million nurses when they're all banded together. So we've got the ability to do this. It's just that we've got to get the organizations behind us and get them involved with the lobbying action again to make that happen.
From where you sit, do you see a disconnect between our clinical and our research endeavors?
Yeah, the question is there a disconnect between our clinical and our research endeavors? Absolutely. I think that's one of the reasons that the DNP is such an exciting opportunity for us, because that role really is a role that's saying we have got to translate research. Whether I'm doing leadership or management, administration, or anesthesia care, I've got to have that evidence base. I've got to know what it is and I've got to know how to use it. And the DNP is deliberately being educated to be able to do that translation and to be able to change systems and to be able to work with health policy, especially at the organizational level with patient care policies. So we need to get them educated, first of all, and secondly, we need them really to in positions where we can push that aspect of what they can do.
Really do that bridge,
Yeah, because we do have the same problem every other discipline's got.
Yeah, and when you talk about unification, that's just been obviously.
The best estimate that people have is that it takes 17 years to move something from research into practice. That's an NIH estimate. It's ridiculous. Okay? So I'm so excited we've got an infrastructure that may help to shortcut that. Yes.
That was great review. Thank you very much. But I was just pondering on one of the things you said earlier about nursing also benefiting from the other institutes, the early days, and certainly we still do. But also the fact that nursing is, I think, unique in being the only discipline that has its own institute.
Has its own.
That has its own institute of
Thank you.
NIH institute. You know, our discipline has an institute of nursing as opposed to heart lung, heart, lungs, allergy.
We're not an
I
organ.
mean, and so we
A body organ.
yeah, we're not a disease, we're a body organ.
Yeah.
We're a profession, and I'm just wondering what your thoughts are in terms of that organizational structure. It certainly has benefited us, particularly in establishing us as a scientific discipline. But in other ways, in terms of lobbying for money for nursing as opposed to heart disease, just how do you reconcile the push for interdisciplinary collaboration at a time when we have a nursing institute, even though I know we do fund interdisciplinaries? How do you see that fitting together?
A couple of things. One, there is an institute for dentistry, though there are two of us. But it's not good in that sense. I know that Pat Grady did a lot of thought about whether she could convert us to an institute of health promotion, an institute of health. That's already the title of all of the institutes. She looked for ways of being able to do that, and they have not found one. If you think about nursing research, it is very broad. So trying to encompass it like you'd encompass an organ, a body organ, is not going to happen. So instead of that, what we might well want to do is choose. Heart, lung, blood shows how they decrease cardiovascular disease. Can we choose several things? Chronic illness, one. That's a big thing for people here, and it's a big thing for our country. And the demographics are going to shove us that way a lot quicker as well, okay? Because I'm one of those people. Why? Those are the kind of things. Let's choose a couple, maybe three, that we can really speak to heavily, that we make a big difference on. And we've got data for that. We have good data for that. And there's no reason why then, if we all spoke to those same things, those same issues, that we couldn't do better. Now, the 75 specialty organizations are going to talk about their thing. Mm-hmm. So we're going to have to give them something in a research abstract that says, here's what affects your specialty. Can you sell that one? And so, it's going to be a lot of work to get each of these together, but we can do that. We've now got the research base, and we've now got the professional infrastructure to make that happen. We just got to get it unified again. Yeah. But I don't know that we can get away from the discipline piece.
I don't know that we want to, but I think that it's a limiting factor in a way.
I know, and I think it is one of the things that distracts. But I don't know what to do about it. Pat's talked about it a lot. She doesn't know what to do about it. Any of you get any bright ideas? I'm sure she's open to them. And I think Margaret's trying to tell me it's time to sit down. Thank you, everybody.
Join me up here. Thank you so much. We have a tradition
Oh, nice.
for our Bellos speakers that we give you a poster of, usually it's just one speaker. Today you get a whole day's worth. But thank you so much for being with us and being the leader that you've been and a great alum of
Thank
the
you.
School of Nursing.
Thank you.